Okay. Well, before I share the PowerPoint, then we'll have a little bit more time. I want to kind of share with you a little bit about my personal journey with motivational interviewing. This is something I'm really passionate about. And if any of you were on my tobacco talk last year, we were talking about sort of medications for tobacco. My journey into being a tobacco treatment specialist really kind of helps me learn this motivational interviewing skill that I understood in my head, but I think understanding it in your head and learning how to practice it are sometimes two very different things. And so, although I'm going to talk about a lot of foundational things today and how I review it, if we finish early and anybody wants to try to practice some motivational interviewing scenarios over Zoom, I've actually done this kind of interactively to sort of demonstrate some of it. But this is something that is really about how you as a provider have to change. It is not the way I learned how to interview people in medical school. And it was really a huge like brain shift for me to try this. But I love it. And I jokingly sometimes pretend that I say, you can use motivational interviewing on your spouse and your significant other and your children over 11 if they have abstract thinking. It works wonderfully to motivate people and recognize positive behaviors and help people be part of their care. So I've totally drunk the Kool-Aid of success with motivational interviewing, and I really try to use it in many ways. And I find patients really like it, even just basic histories. It's just a very different feeling. Many of you may have been doing this far longer than me, but I just wanted to share what a brain shift this was from how they used to teach us how to do interviewing. So if it feels like that to you, it certainly was that for me. But once I got a little more skilled at this, it just is really phenomenal and made me feel like a better doctor and get more results. I think I was kind of in the giving all sorts of recommendations that I felt like no one ever listened to. And this is what really helps me have patients have more success too, is to make them essentially part of the team. So with that in mind, I will launch into the didactics. As always, I cannot see the chat during the presentation. So please, if you have any questions, I never mind if I'm interrupted, just turn on your microphone and jump on in, okay? So let me get this shared. All right. So we're going to talk about like just behavioral approaches. We're going to talk about some definitions of motivational interviewing, talk about the techniques of motivational interviewing and some of the spirit behind why it works, and really just hone in on some basic techniques that we can do to really help shape things. And so this is something everybody on this positive behavioral support team that's joined me already knows, but this is really, really key to anything that a patient comes with or client comes with that reports a behavior. And we're really good at learning all about that behavior. What was the behavior? How long did it happen? Why was the behavior a problem? What kind of, how long it had gone on? What made the behavior better? But you really cannot really adequately change a behavior unless you understand the A and the C. And so this may, especially with children, sometimes the A and the C is not immediately obvious to the family or the caregiver, and they really struggle sometimes to understand those aspects of it. So sometimes I actually have to teach families about the A and the C, because I really can't change the behavior or hope to change the behavior until I get more information about some of the things that lead up to the behavior, the triggers, the stressors, maybe patterns that might make the behavior happen. And then ultimately, what purpose does the behavior serve? You know, I tell this, I love this example, but you know, if the behavior is my child throwing a tantrum in the checkout line of the grocery store because they want a candy bar, and the behavior is the tantrum, and I give that candy bar to the child because I want them to stop, I just really taught them to keep throwing the tantrum to get that candy bar, and the best way to get the candy bar was to throw the tantrum, because that was the consequence. And so sometimes those things get inadvertently reinforced, and it really is important to kind of look at that. And sometimes when we're desperate as parents, or especially like a behavior that we want to cease immediately, sometimes the things that we do kind of we don't realize may actually make changing that behavior worse. And so it really, you have to understand what the behavior accomplishes. The other example I like to give about the consequences is, a lot of anxious kids struggle to go to school. And one of the things that often will happen is that sometimes behaviors will occur, like a kid acts out, a kid doesn't go to school, a kid punches someone. And the ultimate goal of the consequence of that behavior may be to avoid the stress of being there, which will inadvertently be a reward for how they are coping. And so sometimes the things that are happening are good, and sometimes they might be reinforcing it. So as you really try to dig into anything, you have to really understand all three aspects of that behavior. And often it's not something you can do the first visit. So what are some behaviors that interfere with health that we frequently see that might be sort of maybe a target for motivational interviewing, or to really try to understand? So smoking is obviously one, or any type of substance use. But we can really make a difference sometimes with other behavioral changes, such as unhealthy eating habits, medication compliance. You prescribe it, but they don't take it. Why is that? Avoidance behavior, like being late, being tardy, procrastinating, missing appointments, excessive spending, or a whole host of other kind of behavioral things that are challenging or causing dysfunction. And so motivational interviewing all sort of relies on this concept of ambivalence, that it can be a lot of different things: uncertainty, contraindication, unsureness. But ambivalence really matters. It kind of turns out that the reason we don't change is because there's usually something about our behavior that we like. And understanding what we like, or what we like about the behavior, what the behavior does for us, is just as important as understanding the dysfunction. And so when people can start talking about that ambivalence, why they might not want to change, that's a surefire way that motivational interviewing may be very helpful to them. It's not something where we sort of assign blame or confront, but it means that we need to understand it. It's like that light bulb. Oh, I want to understand, what are the reasons this behavior stays the same? What are the reasons why the patient might want to change the behavior? And it's a lot of conflicting emotions and feelings that you kind of accept as normal in the process. And it evokes this idea of thinking about change, and what change might look like, and what the pros and cons of that change may be in this sort of exploratory phase with a patient or client. What you're trying to do is, in this understanding and talking through it with the patient, is to develop this discrepancy, this idea that the patient sees a gap between what they want and this specifically behavior that may not really be getting them what they ultimately want. Even if it's helping in the short term, may not really be helping in the long term. And if you can identify discrepancy, that also will be sort of part of understanding and dealing with that ambivalence that might exist, or why it's so hard to change. Because frankly, I could eat better, I could exercise more, I could do a whole host of things that I don't do, that I need to do, but there are reasons that I don't, and recognizing what those reasons might be may be part of the reason I'm stuck, and we have to work through both ends of it. So this is not the same thing as motivational interviewing, but often it is linked to it. This is this concept of where someone is, of the idea of changing a behavior. And pre-contemplation is like they have no clue. They've never thought about it. They've never considered it. It's maybe a foreign concept to them to change. Contemplation is the idea of thinking about it. Preparation is taking some steps maybe to make a change. Action is actually starting the process of change. And maintenance is once the change has occurred, that you try to not fall back into those old patterns. So motivational interviewing is maybe a tool to move people to a different level. So if you're successful with motivational interviewing, you might take someone from pre-contemplation and move them to contemplation, or you might take them from preparation and move them to action. And this is a process. It may take several visits, several sessions, you're not going to be successful at moving someone from pre-contemplation to action in one fell swoop usually, and that's not the intent. But over time, you may see that process getting you to more healthy change of behaviors. And so here are just some examples, again, regarding smoking. Pre-contemplation would be, I would like to stop smoking. Contemplation is I want to be like smoke-free by July. Preparation is I'm going to start getting rid of those ashtrays and getting rid of the things that remind me of smoking. Action is I actually went out and bought the gum or the patch. And I picked a quit date. And maintenance, I've been smoke-free for a year. So you can kind of think about where whatever behavior you're targeting, kind of think about where that person is in the concept of change. So what motivational interviewing is not actually a therapeutic intervention. It's not a therapy per se. It's really a tool. It's a clinical tool for clinicians, for us, to help somebody that isn't self-motivated or ready to make that change themselves. And there's a lot of buzzwords with this that really matter, and people will often talk about the spirit of motivational interviewing. Because it really is meant to be collaborative, and that's really important in medicine, because often, you know, this is certainly much more common in therapy world, where we talk about kind of engaging and working with our clients, but medicine is inherently kind of this power differential that often happens, where it's almost like the physician or the healthcare provider is sort of the boss, and the patient feels sort of like they're responding to that, and it's really the antithesis of that. It's sort of the healthcare provider and the patient being a team and collaborating to explore their reasons, and also as clinicians just accepting somebody where they are and realizing that my success as a provider isn't about getting someone to stop smoking or not. My success as a provider is actually trying this to get the person more likely to be changed and be there for them if they change their minds. And it's a very different sort of perspective from it, and it is totally person-centered. Which is really, again, this concept of whatever we come up with in the plan is totally okay with that patient's desires and needs. They agree to it from the get-go. And if I have time, I'll share with you a bit of a provocative story about how I learned what patient-centered care was. That's slightly embarrassing, but a good sense of that. But I'll save that one for the end if someone wants to hear that. But it really is about what the patient is willing to do than what I might want them to do. And so there's this idea of these principles, this spirit that you have to engage in with this. And this is really kind of the important part. And this is really that important part that you have to kind of work on as a provider yourself. I'm sorry, my phone is blowing up at the moment with people wanting to know where to be. Sorry. So again, this concept of being empathetic, acknowledging the frustration is really, really important. Like, it is really hard to change. If you can't quit smoking, I want to experience that with you. And I want you to know that I understand that this is hard. Reflective listening is a concept that we're going to spend a lot of time with, and reflective listening is really quite a difficult thing to do. Again, I think that therapists are much better at this than physicians. It is very hard to articulate that you heard somebody when your mind is going a million miles an hour, and listening is the goal. Letting that patient know you listened is the goal. It's not fixing it. And that's a big change that you have to come to the table with this. It's not the end point, it's the process of understanding it. As you talk, you're trying to help them realize those discrepancies. And this is completely and utterly non-judgmental. And we have to sort of remove the embarrassment or the shame someone might have about a behavior that's being a problem. And again, just meeting them where they are. And I always tell people, lead with understanding. If you come to the conversation just trying to understand it as opposed to fix it, you are probably halfway there at doing motivational interviewing. this concept of rolling with the resistance. So when someone doesn't want to do something, or they tell you they don't want to do it, that's actually a good sign that they're sharing with you a barrier, and you kind of just roll with it and find things that they may want to work with. And then it's really, this is a very therapeutic process, even though it's an interviewing technique, to feel heard and to feel supported, or even acknowledge that there's hope despite all this ambivalence, is a really wonderful feeling for clients. And I tell you, you know, if most of the complaints in medicine are that providers don't listen or don't have enough time, these techniques are like perfect to raise those Press-Ganey scores and patient satisfaction, because that is really what it's about, making people feel heard. And so this is a very hope instilling process for patients, and ultimately it's really actually pretty hope instilling for clinicians too, because as much as you want to tell people to do something, that doesn't really change behaviors, but guiding somebody to make their own changes really does lead to success, and is also phenomenally fun as a provider to experience with them. So again, this is just being very open-minded. This is the concept that you do a lot more listening and asking than ever offering advice. In fact, we'll talk about that. You have to invite yourself in to actually offer advice. We're going to talk about the concept of open-ended questions and just conciseness. You probably need to spend about 20% of your time talking and let the patient do 80% of the talking without interrupting. This is cooperative. The patient is viewed as the expert, that they are the expert on their current behaviors and needs, and you're trying to help them utilize their own strengths. And you're really kind of being the detective. You're really helping them investigate the pros and cons of their behavior. It's not just being nice to people. And as I said, it's not just some technique, but it's a style that you have to kind of continue to work on. It doesn't work for everything. And it's not the same as that theoretical model of change, but it may move people through it. And it's definitely not being directive. So these are just some concepts that are really important when you learn MI, just this spirit of acceptance, compassion, this idea of evoking, meaning you're kind of inspiring change as opposed to directing it, and just being very collaborative. And then there are these processes in the course of doing MI where you kind of think about where you are in the process with the patient. You might just be starting with your patient or client, and how do you engage with somebody to meet on those goals? How do you focus what the agenda of the appointment might be? Then you go into things like really that process of evoking and understanding why this patient might want to change. And then plan, how do I actually take some of these things that we've discovered in discrepancy and really setting achievable goals. And so I'm going to go through this really quickly, but you know, these are things you can ask yourself where you are with someone. If you're in the engagement process, you're thinking about, you know, is it comfortable? Is this patient talking to me? Am I being supportive? Do I truly understand what this patient's concerns are? And is this a comfortable conversation? And does it feel like a partnership as opposed to that power dynamic? Once you start there, then you can move into focusing. As the patient feels more comfortable and tells you more, you can start focusing on what the patient's goals might be. What are things that that I might be feeling in myself that might be in conflict with actually what the patient is saying, and how can I be aware of that? Are we working together? Are we moving together? Are we still in opposite directions? And have we agreed on where we're going? And this concept of a dance is really an important kind of concept with MI. Are we moving together, or is there awkwardness in that process? Evoking is kind of deeper into the work, and we'll talk about the technique specifically, but evoking is really, am I getting at that is the person telling me what their reasons are for change, and is there reluctance about this? How is the patient's confidence about their change? And then we're going to talk about the concept of change talk and sustain talk, and am I really listening to those things? Are we going too fast? Are we going too slow? Are we going too much in one direction? And am I pushing? Am I feeling like I'm pushing or pulling as opposed to letting the guiding and following? are sort of that evoking. And then planning is now when we kind of have this commitment, we've worked on our kind of rapport. Are we taking reasonable next steps in this plan? And instead of, again, telling people what the plan is, letting them kind of vocalize their own goals and deadlines. And again, back to this point, if I'm offering advice, did I invite myself in to offer it so that I know the patient wants it as opposed to me offering it? And just at the end of the day, always reflecting back on this concept is what we're talking about really what matters to the patient and not just about what I think might be best. Which if you've done all these things, you should have a good answer to that. So again, some just concepts again, like this idea of if I'm going to offer you advice, did I ask your permission before I offered it? And if you said no, I don't want to hear it, did I respect that? Instead of confronting or disagreeing or arguing or blaming, am I really just supporting and validating? And this is really about that the patient is in control of their own choices and ultimately going to own control of their health behaviors, but that I gave them the opportunity to involve me in that choice. So this concept of asking permission to give advice is kind of really tricky. You know, sometimes we sit here as sort of the expert on things, and we want to share all our knowledge with people. Often behavioral change is not a knowledge deficit. Most of the time people know the behavior is unhealthy or they know what the problem is. And offering your advice about that is really not in the spirit of this, unless you think the patient really doesn't have the information and you'd like to share some things with them. So, you know, how do you invite yourself in to share it? And if you invite yourself in and they say no, you have to be okay with stepping back from it. So this is more, you know, could I share with you some more information maybe about medications that might help you quit smoking? Could I offer some information about maybe some of the immediate benefits that you might have if you chose to do this? Or you can even ask, would it help if I suggest some things that I've heard helped other people? Again, and if they say no, you walk away from it. Because then if you start offering the advice, they already gave you permission to. And it's often not confrontational. Does anybody have, before we kind of get into more of the directed skills, does anybody have any questions about that sort of spirit, that sort of basic concept of this before we like actually go into what you have to do in the process? No, you're experts. Okay. Well, experts on the theory. We're going to go into the technique. Okay. All right. So they talk about the skills section as being like, how do you do the interview? And they talk about the ORS techniques, and these are the 4 skills that you do as the interviewer. The most important of that is this idea of open-ended questions, and we'll talk a little bit more about that. Is how you ask the question really matters. Affirmations is a concept of validating pro-health behaviors. Reflection is a mirroring technique that we'll get into, and then summarizing is trying to put it all together. So, whoop. Okay. So an open-ended question is just one that you can't give a yes/no answer to. It really makes the patient or client verbalize more information. It's a way to ask a question to just not let them shut you down or give you vague answers. And it really, if done right, it's sort of like the client's going to tell you everything. You don't have to target in the question. They're going to lead you to the right answer. So things like, how important is smoking to your daily routine? Is again a different way to ask the question, and it lets them talk and tell you what the feelings are that go in with that. It's also worded in a very non-judgmental way. It's framed in terms of, I'm curious about this. If you were told you couldn't have a cigarette, how would you feel? Again, sort of evoking some feeling and emotion, but requiring elaboration. The two hardest things in therapy are yes/no answers, and then the I don't know. And I don't know can still be an answer to a closed-ended question, but it's a lot harder to say I don't know to a truly open-ended question. Tell me your concerns if you tried to stop smoking. Again, curiosity, open-ended. Now, affirmations are a little bit tricky, and sometimes when we get in our like cheerleader mode to encourage people, we can overshoot this and be kind of too affirming or too cheerleading. And so it's really important that when you affirm, you're only affirming appropriate behavior. So, and it has to be really specific. You know, a lot of those good jobs, great job, you worked really hard, that's pretty non-specific, and it can feel kind of disingenuous. So a really important part about the affirmation is to be very specific with what you're affirming, and also being very, very making sure that you're choosing something that was really pro-health. So an example of that might be if someone comes in and they're like, I don't want to be here. I've tried to quit smoking 1,000 times and I just hate this place. You have to pull out the affirmation in that. Wow, it's pretty amazing. You've tried and been working at this 3,000 times. That takes a lot of dedication, right? You're affirming the positive behavior that you want out of that. And so you also have to really listen for the positives, and which might be sort of funneled in a lot of negatives around it. So again, you have to hear it and you have to verbalize it. And sometimes the value in that is you affirming it also helps the client realize that there's positivity in that sort of process of developing ambivalence. The reflective listening is by far the largest part of this, is that are you really listening to them? This is something I think physicians are terrible at. I was really terrible at that. My mind goes so fast. I know I listened and I'm thinking about it. The patient has no idea that I listened. And it can feel a little weird to reflect back what they just said. And sometimes I've had medical students tell me, that's weird. I feel like I'm parroting it back. That seems sort of like I might be demeaning to them, but it's really not. When someone says back to you, like in a way that they heard you, like it feels really good to be heard. And people can't read your mind. I say all the time, no, I didn't go, I've been doing this a long time, but I've not developed the ability to read minds or have you read mine. And yet I can tell people what I'm thinking if I share with them what I'm thinking. And often it's this concept of reflection. So a simple reflection is literally just rewording back to what the patient just said. I love smoking. It's the only thing that helps me relax. A simple reflection would be to say after that, smoking really helps you relax. Again, just really, and if you're paying attention to the cues in the room, if you got it wrong, the patient will correct you. You'll see that change in their face, or if you didn't have it right, they'll let you know. Complex is is when you hear a lot of different things and maybe reflect back a couple different things at once, but it's just taking almost verbatim, turning it around a little bit and saying it back to you. And this is weird if you haven't practiced this, because we don't go around in this idea of this, but this is really what validating feelings really is. And it really makes sure that you understand and the client knows that you understood what they said. And as you're listening, you're also listening for this concept of change talk or sustained talk that the patient might be having. So change talk is the listening for all those reasons that the patient might want to change their behavior. Sustained talk is listening for all the barriers they experience that might make changing their behaviors challenging. And so there's an acronym for the change talk. Am I hearing some desire for change? Am I hearing some ability to change, like things I've tried before or not tried before? Am I hearing what they're telling me their reasons for maybe wanting to change are? Are they telling me they need to change? Are they voicing any commitment to change? Are they taking any steps for change? Or starting some activating behaviors? And if you hear that, that's change talk, and you can probably affirm it. And again, here's just some examples. All of these are smoking examples because we often teach this alongside the smoking cessation treatment, so that's why many of them are. Again, here's sort of just, again, some examples of change talk. I'm sick of spending money. I'm sick of going to the dentist. I'm tired about hearing what my family is saying. I'm ready to give it up. That's all maybe reasons that people are saying they would change. So sane talk was like, it just helps me with stress. What would I do if I didn't have any other way to keep stress? You know, maybe this keeps me from doing something worse. I know I can quit. I just am not ready. I'm worried about something if I quit. Maybe if I quit rubbing or smoking, I'll gain weight. And that's just as bad as continuing. So again, that difference between reasons I might change and reasons I won't. And then as you hear in the course some of these change talk things, you can follow it up with more open-ended questions that kind of helps them start thinking about the future and what the world might look like if they acted on that change. And so again, if you hear questions about their desire to change, you can kind of get into the fantasy of the future of, well, what would it be like for you to be different? What would it be like for you not to smoke? If you hear ability questions, you know, do you think you could do it? What could help you do that? And you kind of get them thinking again about the future. You know, are there reasons what are your reasons for maybe wanting some of these things? How important do you need to do this right now? And are you willing? And again, you're getting them kind of thinking that the future could be different in this process. Summarizing is also really important. It's something that you do toward the end after you have a lot of information. Again, I think the biggest thing I have failed at in life is summarizing too fast. And a lot of medical providers think they know all the patient's reasons before they hear them because we pattern recognize and we think that maybe we've heard part of the story again. They teach us in school how to do this so that we don't miss things, but sometimes when it comes to summarizing, we really screw it up. We try to summarize based on other examples and patterns and not for really listening to the patient. So summarizing is really important. It's an advanced form of validating and reflection, but really make sure you don't summarize until you have all the information. That's probably the hardest thing for some folks to do. The other sort of concept in this idea of change is listening to the terms of importance or confidence. And these are two very driving factors for patients and clients about why they might need to make this behavioral change. How important is this change to them, and how confident are they that they can make that change? And this is where you can kind of throw in a more closed-ended question, is this idea of scaling. Is I want to know how important it is to you or how confident you feel. So how important is quitting smoking to you? How confident are that you can quit? The question gives you information, but what you do with that question is really the technique. After they give you an answer, ask why it's not the lower number. The reason this might be really helpful is it gives people the idea that they already have some success built in, because you're curious about why it's not lower. And you can always go lower. And if you use 1 or 0 and they tell you 1, you say, well, why is it not a 0? Or if they give you a negative number, you would do the same. But you're really trying to get them to realize some of their strengths in those questions, but it also helps you kind of know where they are. And between sessions, you might see dramatic changes. Maybe the first session, the importance is a 1. Maybe as process goes on, they tell you it's a 6. And you can inherently reflect and reward that they their hard work, that they recognize that they have changed on those terms as well. So how this kind of works in an interview, and I'm not sure this shows up very well. Let me see if I can. Is it cut off in your view, guys?
See it just fine. Thank you.
Okay. Is this idea of like how the interview goes. And so the interview with someone and this technique of the interview is really like going through this cycle of ORS techniques. And so you ask an open-ended question, you reflect. You ask an open question, you reflect back what they said. You ask an open question, you reflect back with what they say. If you hear change talk or an affirmation, you affirm. And you open and reflect, open and reflect, open and affirm, open and reflect. And you go, it's over. This is like a very long process. You're gathering all these things. And then when you have enough, you summarize. And then you might throw in a scaling question. And as they say it, as you hear it, you build this rapport and this understanding. And as the course of the interview goes on, you should hear over time more and more change talk. And then that change talk starts moving into motivation. And if you see that there are opportunities to offer hope or offer information that might still, you invite yourself in. So in the example of smoking, as you understand what smoking means to them, what do they like about the smoking? What do they not like about the smoking? Things they've tried, things they haven't. As you hear things that might warrant additional interventions, you can offer it in. So maybe like, could I share with you some information about medicines that might help you cope with that craving? If they say yes, you offer it, and you let them decide if they want to try that. And then you may have them say, well, maybe I do want to try that. And then you work through this dance that occurs with motivational interviewing. So again, understanding really that A and that C of behavior is key. We're really thinking about the concept of how do we get people to change through this process of truly understanding and connecting with them. And we talked about, again, some of the key techniques: open-ended questions, affirmations, reflections, and summaries that we do in our listening for change talk and sustained talk, and the idea of scaling to really kind of get at that curiosity that people may have around what is affecting their behaviors. And so some references there at the end. I want to thank the School of Dentistry. There's a tobacco treatment training program again in May if anyone is interested in that. It got canceled this year because of COVID, but we actually do a lot of workshops on motivational interviewing and building that. And the provider's clinical support system that does a lot of the provider-based subscribing of Suboxone and other medical treatments. I borrowed some of their slides that also has some interventions. So we do have about 20 minutes, and I'll take questions, but I wondered if I have any brave souls that might want to do a little motivational interviewing with me over this. And you can sort of, maybe I'll let you pick if you want, channel whatever behavior problem you want to come with, and I will be the one that tries to demonstrate some of this motivational interviewing things for you, and we can kind of label it afterwards. Is there any brave soul with acting skills that would like to be I want you to be incredibly difficult and uninterested in anything that I might have. You might not even want to be here today. In fact, the angrier you are, the better. Is there any brave soul that wants to do a little mock role play with me?
I think that's a wonderful idea, Dr. Swagger. We did get a question in the chat, so I don't know, would you prefer answering that question and then have some people kind of brainstorm if they'd want to speak up and do that role play with you?
So the answer, I guess, is about the sustained talk is you just keep reflecting it back and you try to understand it and you validate it. It's really hard to stay angry when someone's like validating your anger, which I'm hoping that in this example, in fact, the more negative you are, the less interested you are in change, the better for this example, because I'm going to just keep doing that the whole time. In fact, and here's the thing, even if you do nothing the first visit, and this is what I tell people, it's not about what if they quit or not. You have to let go of the idea that you have to change the behavior. If you do nothing, the behavior is going to stay the same. You can't screw it up. The only thing you can do is possibly help. So if you're just a nice person that lets the person be angry, they might come back to you when they're ready to actually do something different. So sometimes it's just being the holding space for all of that sustained talk, or just sitting there in the misery of how hard it is to change, and feeling validated and this is really hard is really sometimes that first step. And so hopefully, I don't know, I've had some people start yelling at me over these things. More yelling the better, because as I said, sometimes people are really angry, and it's the same kind of concept. This is hard. So any brave souls?
I can do it if you want.
All right. Okay. So what do you want your behavior to be?
How about smoking cigarettes?
Smoking. Oh, hello, David. Welcome. I'm Dr. Swagger. It's nice to meet you today.
Nice to meet you too.
How can I help you today?
Well, I've been thinking about quitting, but I'm not sure.
You've been thinking about quitting, but it sounds like you're not quite so sure if that's something you want to do.
Yeah, I mean, I know it's bad for me, but I can't stop now. I'm used to it, and gosh, when I don't have my cigarettes, I have the worst day.
So cigarettes, there's a lot of things you've found that are helpful for your cigarette with your smoking, it sounds like.
Yeah, I'd say that's about right.
Yeah. Tell me more about your smoking.
Well, I mean, I started when I was like 14, and my parents did it and their parents did it, so it's just kind of normal for me.
Yeah, it's been a big part of your life and your family's life for a long time.
Yeah.
I imagine it would be kind of hard to think about what not smoking would be like.
Yeah, it would just, I can't even imagine it. I'd probably just be miserable.
Mm-hmm. Have you ever thought about what it might be like?
No, not really.
What are the things you like most about smoking?
Well, it just makes me feel good. Not really that much anymore, but it used to. And, well, now it's just a bill at the end of the week.
Meaning it costs a lot of money?
Yeah, exactly.
Okay. So that's something that you haven't enjoyed as much. It also sounded like maybe you didn't feel like it was helping quite as much as it used to.
Yeah, exactly.
Okay. How much do you smoke?
I smoke about a pack per day.
And how much do you end up spending on cigarettes?
Oh, way too much. I'm not sure, but my wallet's a lot lighter at the end of the week.
Mhm. Is that been a challenge?
Oh yeah, it's a challenge because I have all this other stuff going on in my life, and I can't put the money towards it.
No, you have a lot of other things going on. What kind of other things do you have going on?
Oh, just chronic medical stuff. I gotta pay for my kids and all that kind of stuff.
So what brought you in today? Did you want to make this appointment, or did someone suggest that you kind of come in?
Well, my wife thought I should talk about it with you.
Mm-hmm. And what have you heard from her?
Well, she's just worried about me because she's got a brother who, died of smoking, and she's worried about me.
It sounds like you have a lot of good people in your life.
Yes, I do.
Mm-hmm. Have you had? You said you had some health problems. Have those been affected by smoking at all, or has anyone ever questioned if smoking was impacting those things?
Oh, I definitely do. I have that COPD.
Mm. So it sounds like you do. Your wife is encouraging you. Maybe your doctor with your COPD has been encouraging you to maybe think about something different.
Yeah, exactly.
So David, how important is continuing to smoke to you?
I would like it to not be important, but right now it feels difficult to quit.
Okay, and on a scale of 1 to 10, 10 being completely confident, how confident do you think you could be?
Ooh, I think I'm a 4 or a 5.
4? Okay, a 4 is pretty good. Why is it not a 3, David?
I guess because I've stopped doing other things before.
Oh wow, what have you stopped before?
Well, I used to drink about a 6-pack a week, about a day, but I was able to cut back on that.
Wow, David, that's amazing. You were able to cut back on something else that's really difficult to give up. Wow.
Well, thank you.
How was that experience for you?
Well, it felt great when I finally quit my last drink. I'm 2 years sober now, so
Wow,
uh,
congratulations. That's wonderful.
thank you. And that helped my wallet as well.
Do you think if you could quit smoking, that would be equally rewarding to you?
I think so.
Yeah. So how important is it to you that you quit right now, or think about quitting right now on that same scale of 1 to 10, with 10 being it's like the most important thing I do?
Now that you mention it, now that I'm thinking, probably a 7 or an 8.
Wow. Okay. Well, that sounds really high. Why is that not a 6?
Um, I guess because I'm thinking about it, and since I was able to get over maybe something in the past, it may be not so hard.
Okay. Have you ever made steps to try to cut back or address the smoking before?
Yeah, I tried in the past, maybe about a year ago, but I didn't have anything to help me with it, so I just kind of relapsed very quickly.
Wow, it's really cool that you even tried. So it sounds like we already kind of identified what one of the barriers were to you not having that success. What was it that kind of made it hard to quit the first time?
Well, I just didn't have anything to help me get over those cravings. I needed something in my mouth, and it was just like, I needed the cigarette.
You liked the texture and having something to hold, and that immediate kind of craving was the reason.
Exactly.
Could I share with you some information about maybe some medications or techniques to help with craving?
Sure.
So again, that was very good, David. Well done. Does you see kind of how that flow goes, that kind of dance? You heard me ask open-ended, curious. Again, just getting him to kind of talk and know where he was, and then at the end, kind of like inviting in to offer the assistance that I might. And so I don't know how that looked. If that looked normal to you, if that looked different to you. But David, how did that feel? Just even though you were role playing, how did it
Yeah.
feel to have somebody kind of validate or respond that way? What was your sort of feeling in this interview?
Oh, yeah. Well, I mean, that's the ultimate when it comes to, these kind of office visits that we have day to day in the clinic is if I can get more back and forth like we did, I mean, I think we'd honestly, we'd have amazing results. Most of the time it's, sometimes it goes along the lines of, are you interested in quitting? And I'll say, not really. And then we kind of just change the subject. But with you, it was more like, well, how certain are you could quit? And we kind of rated it out of 10. And, just I think kind of going on a little bit more about it, it kind of opened me up naturally, even though I was role playing. So that was really
Yeah.
cool.
And it feels good to, even if you're angry to like or frustrated, just to hear someone say, yeah, I get that you're frustrated, right? And really if we check the clock, it was only about 6 minutes. I know it feels longer. But I think a lot, even if you can just sort of set kind of one goal, to like, and maybe for this visit we would get into trying a medicine this time if you wanted to quit again. If you can kind of agree on one kind of point in between visits, that can be really helpful. And then the really important part of this is, even if you get nowhere, and this is something to remember, especially things like smoking, even if someone tells you they're totally not interested in change, you can certainly be there. Instead of saying, well, I'll see you next year, say something like, well, how about I schedule you back in a few weeks? Maybe we can talk about this a little bit more. And you can put that in your schedule in a time where you have a little bit more time or a little bit more prep with the focus. And if they don't keep the appointment, then it's telling, but sometimes just opening the door. And if you're using E&M codes for the physicians out there, you can totally build time for these visits. And if you're a therapist, you can actually build time for therapy related to these things, and actually kind of then not feel the time crunch, because if you spend 20 minutes talking to somebody on this topic, you can actually build level 5s for time. And so you can kind of learn some of these things, how to make talking part of the treatment and still be reimbursed for it, but have sort of more wild success, I think, in getting people to change. So even if they give you a no, I'm totally not interested, be curious about that. You might be shocked at what you can hear and order it away. Well, thank you. You did a really nice job. I'm glad I had was there any other observations that anybody had about what that looked like or what it was like watching that? I know this is this is role play, but what were other observations people noticed?
It really helped me to have that example to understand, especially the reflective piece of it.
Yeah, and everybody's always a little bit worried about like feeling it feels fake to say something back to someone. I think at least that's what people have said. Did it look weird at all to anybody?
I think it sounded really natural.
Yeah, but it's not natural, and I think that's really a hard part of the technique for some people is we often think those things in our heads or our nonverbals or like, yeah, but you know, this, I can't even see David, I can just hear him, but it's still really important that you say it. That part's a little bit harder to do, and so you have to get into I'm just reflecting back mode. But as I said, even go home and start practicing on your significant others and spouses. You know, you'd be shocked at how well that kind of, you'd be shocked at how affirming positive behaviors, like, you know, wow, honey, I was so exhausted today. I'm so glad to see the dishes are done. You just made my day. Like that kind of thing can like, I mean, those dishes are gonna get done a whole lot more. It's amazing how those simple things can really kind of evoke things, and they feel good, and they really help us want to kind of continue difficult things sometimes. So I really do live in the land of oars, I think, most days, and I really, it also makes me better as a provider. I really do get to see the change. I think me changing was really the key to do this, because I was not getting anywhere asking people to stop things or do things, and this was a tool I could use to finally get people and me to feel that success, because a lot of people can't change, but this really is a way that, again, it's not about me. I don't make it about me or the success or the failure. It's about the process, and it feels really good. And you will get many more successes with just a few minutes of this, and it is a nice interaction. So thank you, guys. Does anybody have any other questions? Hopefully you weren't as negative as you could be, but again, that sustained talk comes in. Just reflect away. It's really hard to stay angry when someone's validating your feelings, or it's even hard to stay negative when someone's totally validating it with you, but you're not spinning it, you're just reflecting it.
I just wanted to say, I think that is, I've had some motivational interviewing classes before, and I always like to have that refresher, because I do think that it's a very positive, and the patient has, or the client has, kind of has control. I tend to be defensive when people tell me I can't do something, or, you know, you need to do this, or you need to do that, or you're going to keep, you know, I think that, like, as you guys were having that conversation, he came to some of those conclusions himself. So you weren't really telling him. He'd heard it before, but this time he got to maybe take the wheel and be in control. And I think that he's going to leave feeling like, well, this was a good session. I think I have a plan. And he definitely was a part of that plan, where you know, in the common, you know, scenario, we're always told what we have to do, and we kind of shut down. I know I do, and I don't even hear what they're saying, because I know I'm not going to do it.
Yeah, I think that's a really powerful explanation, and I think that word of control is really important. As I said, you won't get anywhere with behavioral change unless the person making the change feels in control. You're totally right about that, because that's human nature. I think we all get defensive, and people inherently know that behavior probably is not healthy, even if they don't admit it. But you kind of got to get through that. That was a lovely summary, Donna. Thank you. All right. Well, as I said, this is definitely something I would say that requires a lot of practice. I've certainly, it took me a long time to make that look and feel natural, because it was real different from the way I did things for a long time. And so I think the important thing is to just keep practicing, and as I said, even practicing on your loved ones turns out to be a good technique to practice. And it really does. I mean, now it's become, I've been doing this for a couple of years now pretty consistently, and it really does become kind of second nature, but it's really hard to, it was very hard to start to shift that, because we do tend to get in our advice giving modes sometimes. But all right, well, thank you, everybody.
Thank you so much, Dr. Swiger. I was going to say I'm not a provider, but I'm definitely going to use the positive affirmations in the household with the dishes and all of that. But that was excellent, and that role play was a really great, natural. You know, you made it look so easy, but I know it's not. So we really appreciate your time and everything. So if anyone does have any questions after the fact, please feel free to email me. I'll make sure to have them addressed. Just a couple housekeeping announcements before we part ways. Our next session will be on August 19th. And we have a student in our community and rural rotation support program who's going to be presenting his first case. So that's going to be awesome. And we'll be having Dr. Swiger finish her part 2 on pediatric anxiety next time as well. So keep an eye out for that reminder. And thank you so much again, Dr. Swiger, and everyone for joining. We'll see you guys next time.
Thank you. Bye.
Thank you.